All right. Hello, everybody. My name is Jared Facundo. I'm one of the healthcare antitrust reporters with the Capitol Forum, and I kind of had something in mind. I had an outline in mind of how I wanted to structure this panel, but just after a quick round of introductions, I would really love to get all of your guys' thoughts on what Michael Kadish just had sort of say, and specifically with respect to like the integration points and our evolution to value-based care. But I guess if we could get started from the far end and work our way up, just work our way back over here, just for a quick introduction.
Yep, I'm Hayden Rookley. I'm a fellow at Brown University School of Public Health and a senior fellow at the American Economic Liberties Project.
Great. Hi, I'm Molly Smith. I'm the Group Vice President for Public Policy at the American Hospital Association. We represent kind of the whole spectrum of hospitals across the country, from kind of the smallest independent frontier hospitals all the way through large academic medical centers and health systems.
Hi, I'm Lauren Adler, fellow and associate director at the Brookings Institution here in Washington, D.C. We're a large nonprofit, nonpartisan research institution.
Hi, Rick Gilfillan. I'm an independent consultant now, former CEO of Trinity Health. I must say, we were seeking to be a righteous healthcare delivery system integrated platform. So I enjoyed those comments. I was also previously the deputy administrator at CMS, going back a number of years.
All right, thank you, guys. Okay, thank you. This is a question for all of you. Can I get a reaction to how Michael had laid out this evolution from HMOs to ACOs and now value-based care? I mean, if you follow sort of like healthcare space, which I'm sure many people in here do, like value-based care is kind of just thrown out as almost of a buzzword. But I think that Kadish just did a good job to really sort of underscore how this is, I guess, like the groundwork for the healthcare payment system. So would you like to start, Rick?
Oh, sure. So I've been around for most of what Michael talked about. I think he's accurate. It's the same story. We had the same story in the 70s and the 80s. And the conversation was about how do we deliver value? And we defined it quite simply as choice times quality outcomes divided by the cost, right? And that kind of was the triple aim in the 1980s. And it's still the buzzword repackaged as value-based care, pretty much with some modifications. So I think that part of it is true. And we have tried multiple iterations of organizational approaches to accomplish that on behalf of patients and also on behalf of providers seeking to do what they were trained to do, namely deliver great care and get great outcomes for patients. But we have had, we've been through these cycles, and I've actually ridden different organizations through those cycles as a former chief medical officer for a large independence blue plan, worked for Coventry Healthcare for profit insurer, and as I mentioned, was the CEO of a large integrated system. I think, in my own conclusion, I thought Michael did a great job. I believe you need competition and you need regulation, and the question is the degree of which you have at any particular time. I think the actual driver of the most significant part of healthcare cost inflation is pricing, primarily on the commercial side, and I think that's largely driven by the reality of insurer-based coverage. And I think it is, as he points out, the insurance-based coverage introduces several levels of those complex decision makers into the process. And so I think, I don't believe marketplaces will deliver fair pricing in healthcare, so I believe that we need to go to government set pricing on the commercial market. And I would say ultimately a public option that does that and that is offered at the individual level greatly simplifies the dynamics around that decision making, as he mentioned, and I think would be one very important step in taking us further towards creating a more simplified marketplace that will actually discipline what we have right now, which are price takers on the commercial side. More to say about MA and other things.
Yeah,
Those are my
course,
antitrust thoughts.
Yeah.
Oh, and I'm sorry, just one last thing. It's not about primarily it's not about consolidation. It's about market power of providers that is driven by the need to include them in commercially sold networks in the employer space. That's why employer insurance is the key piece to understanding the exercise of market power, I believe, in pricing in the commercial marketplace.
Do you want us to go just down the line or just jump in?
Go ahead and jump in. Yeah.
Okay.
Go for
Or
it.
lunch.
That's fine.
So a couple of things that I was thinking about when he was talking particularly about the evolution is that, I believe a lot of the evolution came from just the increased complexity in the healthcare system and the need to help patients navigate healthcare in a way that, frankly, maybe 75 years ago either wasn't an option or there wasn't enough healthcare really, and the level of complexity of healthcare where that was necessary, but also demographic shifts and things like, for example, today, just how many people live alone and how family structures look differently. And so we're just in a very, very different environment, which is what I think has contributed to a lot of these efforts over time. I agree that entirely that what is really hard to assess in terms of integration for the benefit of patients and patient navigation and quality of care and all of those things can look on paper or I guess in contracting very similar to vertical consolidation that is where the ultimate objective for an entity is kind of profit. Because frankly, you need sort of all of the pieces of the puzzle in order to achieve both of those things. And so I think one of the things where we just really struggle as a country is what are the metrics that we can use to assess whether or not integration of providers, and sometimes it's providers with health plans and other entities, whether that integration is for the benefit of society and for patients, or if it is to the benefit of the bottom line of a particular company. It is possible, perhaps, that those two things can both be true, but I think that we first need to really hone in on those metrics, and that's where I think we've really suffered. And frankly, it's an area that we worry a lot about because where we see some of the greatest innovations and some of the greatest performance already in terms of patients' ability to access care, the ability to remove the right type of utilization without compromising access to, without compromising access. That has often happened best in organizations that have tightly aligned relationships between not only physicians and hospitals, but a whole swath of other providers, post-acute care providers, community partners, et cetera. So we're very aware or very sensitive to the fact that we need these metrics and we need to figure them out now so that we don't unnecessarily stifle that kind of innovation that is truly going to be sort of the best thing for patients overall.
Go ahead, Aidan. Yeah.
Sure. So I also appreciated particularly the characterization of us sort of being in a repeating history a little bit here as we, I think, move from the 80s and the 90s of sort of managed care HMO days into value-based care, accountable care organizations. And I do think it's correct to frame this as sort of the same idea and the same kind of approach to health policy we're really working on 3-4 decades now. I think that a notable difference is that we really sort of after the backlash to the managed care movement, HMOs of the 90s, the policy response, quite interestingly, and I think quite notably, was actually to try to basically double down on those models, but to do so in our government programs. So a lot of the HMO movement in the 90s was really on the commercial side, produced a lot of backlash from, I think, clinicians and patients, a lot of consolidation on the provider side as payers were trying to move providers to risk. The response here was an investment initially in the early 2000s in Medicare Advantage. And then I think the Democrats really sort of embraced that theory of managed care with the Affordable Care Act when we're talking about sort of the value-based care elements of it. And I think, the way I would characterize this is a particular interest in a particular obsession from the policy side of things on utilization, a lot of what you just mentioned, actually. And I think this is actually where we've been led astray a bit. I think there's been so many of the justifications for the types of vertical consolidation we've seen whether it's from the provider side, hospital systems vertically integrating, or more recently, whether we're seeing the big payers, particularly the MA payers, vertically integrating, is based on this idea that we want to try to control our costs in our healthcare system by managing how much patients use the healthcare system. And I think that's actually the central flaw that's driving the wrong sort of policy paradigm right now. And I agree with what Rick said on solutions. I think we need to have much more of a focus when we think about cost containment on the side of administrative costs and prices, and less of an interest on essentially having big hospital systems or insurance companies manage clinicians and manage patients and how much they use the healthcare system. If that's the paradigm we're going to continue to operate in, it's going to be very difficult for us to move past, I think, a lot of from my view, the concerning developments we're seeing both from big consolidated hospital systems and from now vertically integrated insurance companies. Again, I think the sort of conceptual flaw here is this interest, this obsession, as I would characterize it, on managing how much Americans use the healthcare system. When we've long known, dating back decades, that's actually not what really drives excessive costs in our system. What's notable about the American healthcare system is that our prices are exorbitant, and our administrative costs, which oftentimes are a function of those prices, are extremely high. I think that's where we ought to focus when we talk about managing costs, worry less on the utilization side. And I think that would help us move away from some of the concerning consolidation patterns we're seeing.
I'd also just add, I think that's where there is a slight difference here between the sort of 90s push towards HMOs, which were a little bit more about, yes, there was sort of a coordination of care argument, but there also was a, actually selectively contract and actually use that as leverage to push back on pricing, where, yes, if you kind of were somehow able to magically encourage narrow networks, that might have that effect. But that, again, is back to prices being the kind of, right, prices are the reason why we are an outlier compared to other countries on costs, not utilization. So I think it's sort of two things. I think, right, in the commercial market, that's where the sort of HMO push was a little bit, or could have been a little bit focused on price, and the sort of value-based care movement probably isn't gonna do a ton in the commercial space, right? It's a little different in Medicare, where we do have set prices, and there, right, the sort of movement towards ACOs and other value-based care in a lot of ways is trying to outsource some level of utilization management, right? I think, MA maybe really has too much utilization management. Traditional Medicare probably has too little. And the government sort of doesn't want to be in the business largely of making those utilization management decisions. So honestly, I think some part of the sort of value-based care wave here is to sort of get someone focused on making some of those decisions. Obviously, there is a broader argument of that, right? There's sort of the grandiose, verbiage around this towards coordination of care and quality of benefits should be is still important, but I do think some of it is really about that.
Yeah, and I appreciate that distinction, and I agree how Lauren characterizes the difference between the interest in HMOs, or the ability of HMOs dating back decades to be more emphasized on the commercial market, more pressure to bring down prices. And again, notably, we've decided, okay, the policy move was let's go do the utilization management on the public payer side. And what that's caused then is that we've sort of, I think, ignored the pricing side on the commercial side. But I would push back a little bit on the idea that necessarily, doubling down on the sort of, let's call it the utilization-based focus, even in our public programs, might not be problematic. Again, I think this is actually at the core of why we've permitted the MA program to develop the way it is developed. So at this point, we're now spending, anywhere in the order of 80, 90 billion, $100 billion more in Medicare Advantage than we are in fee-for-service. A staggering amount of money. That's really hard to overstate. And I think there are a lot of explanations for sort of why we've gotten here. One can just be corporate capture of DC. Another, though, could be there's a halo effect, I think a veneer that MA has around its ability to innovate and to manage utilization that I think a lot of policy folks are still really attracted to. And I think that's made folks reluctant to move away from this model, which at this point is just an incredibly wasteful program. So I think some of that utilization-based paradigm is prohibiting us from addressing, again, what would be the more direct ways to reduce waste in the system, even in our public programs. And MA would be a good example right now. You've got to pay for on the table of $90 billion a year relative to traditional Medicare. I think we have to think about the sort of policy paradigm that might be driving why there's a reluctance to move off of that and move towards the type of system. You know, nobody wants to say, let's go back to like the fee-for-service based system. I actually think we need to have that conversation.
So I actually have a question for you, Rick, that I think kind of gets at some of the points that Lauren and Hayden have been sort of brushing around. I'm just wondering, with the growth of Medicare Advantage, what are the incentives that are available, or what are the incentives that industry stakeholders sort of see on the other end of this? I think Hayden was calling it like a paradigm of utilization management. I guess if you're in the private sector and you're looking at Medicare Advantage, why is this lucrative? Because it's obviously grown.
Yeah, well, I think you have to kind of dig deep a little bit into the reality of the dynamics that exist in the MA space, right? So the acquisition of primary care practices is really simple and straightforward. Risk coding in MA provides an opportunity to take primary care practices, which at best are break even after you pay your salary to doctors and all your staff. They're break-even operations. And by the risk coding mechanism in MA that allows plans to get more diagnosis codes, to increase the score for each patient, to get more premium from CMS, that just provides them with opportunity to improve benefits a little bit, make more profits, and basically grow the business to the tune of subsidies of, I would call it $106 billion a year. That's a result of the risk coding mechanism. And the only reason it makes sense to buy primary care doctors for insurance, it's not some grandiose scheme about I'm going to create an integrated system. You could not pay them to buy a hospital, to take a hospital. You know, they don't want that. They don't want integration. They want the risk score arbitrage profit opportunity. Just listen to the United quarterly calls, right? They talk about it all the time, very specifically. Also on the PBM side, you know, I'm not going to go into the obscure world and arcane world of trying to understand the PBM profit opportunity, but it's been evolving over 20 years, right? And so the reason, I mean, Elevance sold their PBM years back because they didn't know how to make money out of it. And then they watched everybody else figure out how to make money. And they said, oh, we can do that too, right? So it's just about pursuing specific profit opportunities. It's not grandiose schemes, I would say, that drive this. On the MA integration side. On the hospital system side, there are drivers underneath it all, right? If I'm going to be capitated, if someone's going to capture my population of patients that I live off as a system because I'm doing all these services, provide all these services, then I got to own the PCPs, right? Because if someone else owns them, they're going to direct them someplace else. So there becomes these very specific drivers. It's not necessarily a grandiose scheme to create market power, because market power comes from a different place. It doesn't come necessarily from PCPs, but I got to have PCPs to have my system continue to have access to populations of patients. And then the value-based care thing, again, kind of doubled down on that notion that if populations are going to be identified by their primary care doctor, right, then I need to own primary care doctors. So that creates that incentive. The result at the end of the day is certainly increasing market power on both sides. But I think you have to look underneath to understand the drivers in each case and then start talking about policy moves that go at some of those specific drivers.
Molly, I saw you nodding along. Did you want to add something?
Yeah, I mean, and I think this gets back to one of my some of my initial comments about the drivers. Again, if you are, look, there are MA plans, frankly, that are trying their absolute best to serve their patient populations. Frankly, there are some benefits that you get in the MA program that you may not get in the traditional fee-for-service program, including caps on out-of-pocket costs and all of that. So, I think that we have to be careful about really kind of looking at all of the pros and cons, and it's probably a shock for most people. We're not normally up here defenders of the MA program, but frankly, like a lot of hospitals have actually even seen the MA program as a way for them to get into the value game in a very in an all-in way. And we probably have about 70 or so hospital systems around the country that have MA plans, because they truly do see that that ability to help their patients navigate the healthcare system, put together the networks that make sense. Frankly, they're often narrow network products that, but that are very tightly integrated and feel like they can deliver value. And it will include primary care, it will include post-acute care, it will include kind of the whole spectrum. They really do see that as a really important vehicle for them to kind of align all of the right pieces of the healthcare system. But frankly, most of our members' experience with MA is as a payer, and there are a lot of these big organizations out there that have, to Rick's point, captured pretty much everything except for the hospitals, because hospitals are incredibly difficult to run. They're very volatile. This is often a losing financial business. So so they don't want any part of that. But so then they acquire, for example, these various other components like the primary care docs, and frankly, that can be very disruptive in a community where you are trying to actually integrate care for patients. And I'll just give you a couple examples. So we have seen, not to get into too much of the weeds, but you may be familiar with like something called site of service policies is a very classic thing that these integrated MA plans do when they want to steer some of their enrollees to various providers. So, we just have instance after instance where hospitals are trying to care for their patients, and mid-year for the enrollee, mid-year in the contract between the hospital and the MA plan, they say, you know what, you're in network, but actually your outpatient surgery is no longer in network for this service. So a patient who you've been seeing for a long time, with your doctor, comes into schedule, and all of a sudden 6 months in, it's like, oh, you can't go there anymore, you have to go over here. It's incredibly disruptive to the relationship between patients and their providers. And frankly, it's very worrisome for the patient experience. This is something that we've been seeing a lot in the pharmacy space, particularly as they've built up their PBM and pharmacy businesses. Infusion, increasingly hearing about, you can't get your long-time, you're on a long-standing cancer or neurology therapy, you need your infusions every month. Nope, you now need to go, 30 miles down the road. So, I think that, again, a lot of times these relationships or these arrangements look very similar sort of from the outset, but it's the same tool that can be used for good or good for the patient or sort of profit. So I'll just kind of leave it at that.
And do any of you guys want to respond to this, like, narrowing of insurance networks and I guess like this loss of negotiating or loss of leverage from the provider? And
yeah, I mean, we've got markets where I think there's just a very recent government report. There are 12 states, for example, where a single insurer has more than 80% of the market share. And the average in every other state is that 3 companies have more than 80% of the market share. And I know there's a lot of concern about provider consolidation, but it is nowhere near that rate. I think where the top 3 in kind of nationally of provider organizations having market share, it's like 44% or something along those lines. If you are a small, rural, or any kind of independent hospital trying to go up against Anthem, United, et cetera, I mean, good luck. I mean, these are not kind of fair negotiations. So in most instances, providers really, it's kind of take it or leave it when you go into a lot of these negotiations. And frankly, even some of our most sophisticated health systems who you would think they're the ones who would have the clout to really negotiate with these plans are really struggling.
Yeah, at the end of the day, market power matters. Market power comes from reputational perception, I think, in the marketplace. It comes from, in the employer-sponsored world, the insurer goes out, talks to the HR department. The HR department says, I got to have this hospital because my CEO goes there, my family members from my CEO go there. So you got these must-have hospitals, and that's just simple reality, right? Those must-have hospitals have market power, and they dictate price on the commercial side, and they control, to a fair extent, even on the Medicare Advantage side, not so much on the Medicaid side because they may not want the business, but when they want business, they can control it. They can also, they have more market power, and they have, because they get their capacity utilization is high in their hospitals, right? They may not need the MA business, right? So they may be like, a place like Scripps. who walks away from it and says, I'm not going to put up with your funny business anymore, MA plans. I'm walking away from it. So the reality is market power plays out across the board. And what you end up with in the hospital system side and the hospital side is, winners and losers, right? The rich get richer and the poor get poorer. And the poor, sit back and they don't have the power to say to MA plans, I don't want you denying or downgrading my hospital claims from inpatient stays to outpatient stays, right? And the big guys say tough, leave, and they can't leave, right? Because they need somebody to fill the bed, even if it's 90% or 80% of what they should get paid, right? So the market power plays out, and until we, I think, address that fundamental driver of market power on the commercial side, I think we're going to have real problems with the system becoming more and more kind of bipolar with winners and losers on the hospital side, and that just plays out in spades in the rural areas or in inner city for safety net hospitals.
Yeah. So I think we've really dove into like some of these problems within like I guess insurers and these vertically integrated systems, but something I wanted to ask you about, Lauren, was what are some of the reforms that are like actually could be on the table in this like next administration? It sounds like from earlier this morning that the exact villain might not be the same across both parties, but that there's like there's a bipartisan sort of feeling about addressing healthcare.
Sure. I mean, in the sort of Medicare Advantage
Yeah,
piece that we've been
let's talk
talking
about like, what HHS.
Yeah, I mean, so in Medicare Advantage, it's unclear exactly where the focus is. I think certainly there is a lot of opportunity to go after and rein in administrative costs and just sort of effectively lower the payments and the sort of additional subsidy dollars that are flowing to Medicare Advantage. I mean, fundamentally, MA is just receiving a higher subsidy than traditional Medicare. So yes, they can offer more benefits, but on the margin, those benefits are, only about 50%, give or take, flowing to patients, right? That seems pretty clear that at least lowering overpayments at some level would be a good use of government funds, sort of almost no matter what else you do with that funding. I may not throw it at at more tax cuts, but that's my personal preference there. But nonetheless, right? I think that's one of the biggest opportunities, but it certainly does not seem to be on the table, in the sort of near term. There doesn't seem to be a lot on the insurer side of the table. There is more on the provider side. I mean, it's not sort of off the topic of this conversation, but there does seem to be continued interest. Well, I don't know, it's a little bit confusing, but some interest on the antitrust side, certainly from parts of Republicans in Congress, to kind of keep focusing on hospital consolidation, to focus on site neutral payment reforms, right? There does seem to be some avenue there. The Trump administration was very aggressive the first time around in those respects, but I feel like that's a little, on the insurer side, I don't know that there's a ton other than maybe some small prior auth reforms, but I sort of suspect those end up being pretty small bore.
So what would some of the distinctions be between what we can expect in the next administration and what the Biden administration had done on the insurer side?
It's a good question because it's not like a ton actually changed on the right. I think we saw slightly slower growth in Medicare Advantage payments, but there's a lot of room, even administratively, to effectively reduce. You can do these coding intensity adjustments administratively to up to a cap, but you can to some degree. It is very difficult, no matter what party you're in, to take on a bunch of large insurers who can also credibly claim that at least some of that money you're taking is reducing benefits to MA enrollees, right? Even if it's 50%, right? That is some of the money was flowing to patients. And right, I think there's this argument that, okay, it's really hard to increase subsidies through the public traditional Medicare program. So, I want, if you're a member of Congress who wants a more generous Medicare program, the only way to do that is to funnel it through private payers, right? I think Medicare Advantage would be a more beneficial program if traditional Medicare could come back regularly and pick up the sort of positives that they're doing and implement an out-of-pocket cap. Right? The most of the way that MA plans save money on utilization is almost all in the post-acute care space, right? Like, there's been policies since the Obama and Bush budgets to reduce payments to post-acute care in traditional Medicare. It doesn't happen, right? Just sort of cribbing from those would do a lot to level the playing field, and I think do a lot to sort of right-size Medicare Advantage without, I think you need to sort of reduce the payments as well, but some of it is just putting fixing up traditional Medicare, putting it on a level playing field, I think would solve a fair amount of the very real problems here.
Could I offer maybe
Yeah.
a different perspective on a lot of what Lauren just talked about would, not all, but a lot of it would require legislative action. There's a lot that the administration can do just in terms of its oversight of the program. And I will say over this last administration, I think that, in at least the kind of 20 years that I've been working in the space, really was actually probably the most active when it came to really paying attention to what the MA plans were doing. Our understanding is the complaints into CMS just have been sort of like through the roof, and CMS listened, and they've done it. They've taken a couple of steps. So, for example, they've established new processes for providers to be able to alert CMS when they're concerned that an MA plan is inappropriately violating access to coverage for a beneficiary. That was not something that was very clear that providers could do in the past, and now they've got a very clear pathway for that to happen. We know that they have been having meetings with insurers when they get complaints, et cetera. So I do think that one of the things that will be very interesting to watch, and I shouldn't just say meetings, I mean, look at the last two regulations that came out, the 2024 rules, the 2025 rules. There was a lot more in there in terms of expectations that CMS set for the MA plans in terms of parity of coverage between MA and fee-for-service. They're clamping down on the ability of plans, for example, to deny coverage for something that they had previously approved. This was all stuff that CMS was able to do on its own. And I do think a big question moving forward is what will the appetite be to continue that level of oversight? Because frankly, it's not just writing regulations, it's a lot of manpower. It's a lot of manpower, within the agency actually, and the authority to go out and kind of confront these plans and hold them accountable. So I agree 100% with Lauren. It remains to be seen, because I think that generally speaking, I mean, it's no surprise, I think it's all well understood that Republicans generally tend to be a little more like hands-off when it comes to the MA program. However, if this last horrific week is any indication, I mean, the public sentiment towards wanting better from their insurance coverage is very, very high. And again, CMS has been hearing that. So I am not sure that we will necessarily go back to totally hands-off, because I think that policymakers do absolutely feel a responsibility to their constituents.
Yeah. Hayden, did you want to add something? Oh, okay.
Could I?
Yeah.
Yeah. I think I've in a couple of conversations, I guess, around town, I've seen a little spark of interest, bipartisan interest in an aggressive level of the playing field approach, which would be to combine elimination of the $106 billion in overpayments with direct important improvements in the TM benefit package, in the traditional Medicare benefit package. So put in an out-of-pocket cap, so people don't have the fear, if they're in traditional Medicare, that they're going to be exposed to some extraordinary expense or have to buy Medigap coverage to get protection against that. So I think there has been some interest, I think, expressed by people on both sides in considering combining that reduction in overpayments with improving a traditional Medicare package. And it's about kind of less money for insurers, more money for patients. And yet that money, by the way, would still support the same benefits for the MA people, right? So they wouldn't necessarily get the flashback of taking benefits away, and at least the most important benefits. And then third, particularly, again, this notion of what we've seen about people's concerns about administrative expenses with the tragic events and shooting and murder this past week, the reaction to that, simple approach, take MA plans out of the business of denying and pre-authorizing care, denying, downgrading payments. Look at United Health's Q1-2 reports on what happened with Change Healthcare hack. They explicitly documented that they make $5 billion a year downgrading inpatient claims to outpatient claims, right? We should not be in the business of having MA plans compete on the basis of how well they can deny care or delay payment or deny payment. Instead, let's create a Medicare Advantage, Medicare Administrative Contractor equivalent, a MAC, that would be responsible for providing all pre-authorization and all claims adjudication services for all MA plans. Simplify the system entirely, reduce administrative expenses on both the plan side and the provider side, and give people a fair shot at getting the care they need, where judgments are made not by a self-interested or a biased organization making decisions about where and when and what care I need, but by an objective organization that does not have responsibility for the profit and loss of the insurance companies. And those, by the way, do require congressional action, or at least I think both sides of that, all sides of that require congressional action. But there's some hope, I think, maybe for some bipartisan interest in pursuing something like that maintains, that actually increases competition and makes traditional Medicare a more competitive product compared to MA, thereby hopefully, making them become more effective.
Thank you. Thank you.
Yeah.
All right, great. We're going to take a 3-minute break, come back with our firerside chat, and get a well-deserved lunch. Thank you guys very much.
Thank you guys.